Hello students, my name is Dr. Laura Harmanova and I'm a pediatrician with a specialty in neonatology. Today's lecture will start with an overview of differences in the physical examination of neonatal and infant patients. Remember, while speaking of a pediatric patient, correct terminology is key, as the term comprises many types of patients in different stages of development. Each of these stages brings about distinct concerns and, therefore, requires a highly specialized approach. When conducting the examination of a newborn or an infant, two aspects serve as key sources of information: history and physical examination. Firstly, the history of the patient must be taken just as in any other patient. However, specifically for this group of patients, it includes the history of the pregnancy, the birth, and the development up to 28 days after birth, the vaccination history, and psychomotor development. Beware that in pediatric patients, parents serve as a valuable source of detailed information and are of tremendous value. The examiner must inquire about any health complications of the mother during the pregnancy, such as gestational diabetes or preeclampsia, as these conditions have a direct effect on the growth of the fetus. Regarding birth history, a cesarean section, use of a vacuum extraction, prolonged labor, breech position, premature birth, or any other complications must be noted. The APGAR score provides a reliable image of the newborn's overall state of health shortly after birth and must be noted in the child's history. The vaccination history of the child should include information about mandatory or recommended vaccinations according to the vaccination calendar. Secondly, a physical examination is conducted. Similarly to a physical examination in adult patients, it consists of the following aspects: inspection, palpation, percussion, and auscultation of the heart for murmurs, of the lungs, and of the abdomen for peristalsis. However, unlike in adults, physical examination in neonates assesses new signs and symptoms, or looks at the well-known symptoms differently. It starts with the assessment of the general status of the child, where the examiner conducts an evaluation of consciousness, height or length, weight, bodily proportion, nutritional status, posture movements, and sound production. The initial phase also includes measurement of the temperature and appearance of the skin. Then, the physical examination of the whole child must be conducted from head to toe. Additionally, in neonates and infants, the following signs must be examined: the fontanellae, which should be on the level of the skull and may indicate dehydration when below or intracranial hypertension when above. We also examine the setting sun eye phenomenon that also accompanies intracranial hypertension, the suck reflex, the grasp reflex, or the Moro reflex, which is present up to 3 or 4 months of age. We need to have a look at the muscle tone of the palms and the fists, and the upper and lower limbs inflection, the Barlow maneuver, and the Ortolani test for congenial luxation of the hip, the presence of a smile at the age of 6 to 8 weeks, the reactions to the voice of the mother and shifting the head to follow the sound, and many more. The psychomotor development of the child must be examined thoroughly and appropriately to the stage of development of the child. Therefore, the list is not exhaustive. Pediatric examination requires many special skills, as the patient cannot communicate, develops quickly over time, and manifests diseases in a different manner. However, those who undertake this difficult task claim that pediatrics, including neonatology, are one of the most rewarding fields of medicine.